Welcome to Verified RX, your prescription for success. Brought to you by the Vizient Center for Pharmacy Practice Excellence.
The Pharmacy Vision Awards at Vizient celebrate values and achievements of our program participants. The Innovation Award is granted to an individual or group who works with others to implement an innovative approach to a challenging patient care or operational practice issue. We are joined by our 2023 winner, Ochsner Health, represented by Dr. Lisa Boothby, Director of Pharmacy at Ochsner Medical Center West Bank Campus, Dr. Johlee Odinet, System Medication Safety Officer, and Veronica Theriot, Director of MedSurg Telemetry Stepdown Unit. I'm Gretchen Brummel, your program host. Welcome to the podcast and congratulations on this award.
Thank you so much, Gretchen.
We're excited to be here.
It's been great.
Tell me about your backgrounds.
My name is Lisa Boothby, and I'm a graduate of the University of Florida College of Pharmacy. I've been in healthcare now for 25 years, practicing in large and small, not-for-profit and for-profit healthcare systems. And I oversee the operations at our Ochsner Medical Center West Bank campus. I've been with Ochsner for 4 years now.
My name is Veronica Theriot, the director of the MedSurg Tele Stepdown Unit. I have about 250 FTEs. I've been with Ochsner for 10 years, and I've been a nurse for 39 years.
And I am Johlee Odinet, the System Medication Safety Officer for Ochsner Health. I've only been at Ochsner for going on about 7 years, but I've absolutely enjoyed my time there. After I completed residency training up in North Carolina, I was lucky enough to be able to move back home to New Orleans and have been practicing at Ochsner ever since. I spent the first 5 years of my career as the medication safety officer at our local academic flagship hospital before moving up to the corporate team, where now I'm responsible and have oversight for the medication use processes of Ochsner Health.
Really rich and fantastic backgrounds. Thank you so much for sharing. Tell me a little bit more about Ochsner Health.
It is a really exciting time to be part of the Ochsner family. We are up to 47 hospitals now with hundreds of clinics spanning 6 of your Gulf Coast states. We have primary service care lines in transplant, oncology, pediatric services. You can throw a dart and we offer specialty services, not just in Louisiana. We're growing very rapidly and have partner facilities. We're in 6 states now. One of the coolest thing about being part of the Ochsner Health family is that we always try to answer yes to a need, to a patient request, to employee engagement. We are always willing and ready to help out where there is a need in the community. People often ask, why are you growing so fast, growing so much? Because when our leaders see a need for the community, we like to step in and fill that gap.
And not only for the community, within our own community of hospitals, we definitely like innovation. We're always ready to try the next pilot and be on the forefront of new successes. This is why our pharmacy pilot and program has taken off the way it has.
Well, very comprehensive. And I love that concept of always being willing to say yes, and adding that to that innovation piece really puts you at the forefront as a leading member of Vizient. And I can see why a number of our leading initiatives come out of your organization. I know there were a lot of folks from Ochsner involved in this project. Is there anyone else other than those of you that are on the podcast that you would like to mention as part of your success?
It was my pleasure to complete the application and send in our project team for the Innovation in Pharmacy Award. And I included everyone that was boots on the ground support on up to director level, but I neglected to include our administrative leaders and support system there. Debbie Simonson is our chief pharmacy officer, and we want to thank her for her continued support of clinical pharmacy services for over 40 years. She promotes integrating pharmacy in direct patient care, along with Debbie Goodlett, that has been a very important part of this project from the beginning. I'd also like to thank Ruth Sagastumi, our CNO of Ochsner Medical Center Jeff Highway, the former CNO of the Ochsner Kenner campus, because she has been an incredible supporter of this program and many other pilot programs. And then Melissa Adams, our CNO at the West Bank campus. Melissa has been a supporter of this pharmacy program and many other programs here at the local level to help us grow and develop our teams to help meet critical shortages from after the first wave of the pandemic on into today. So I'd like to thank our administrative leaders for their continued support.
And I think we'd be remiss if we didn't mention the nurses at the bedside who spent countless hours training the pharmacists on how to administer medication. But definitely want to give credit along to them as well.
And then our pharmacists at each campus, several pharmacists that are in this medication administration pharmacist role now. Labrie Simmons is one of my pharmacists inpatient that asked to be a part of this project. She tells me, I can't wait till I see this program on the news because what we're doing here is so exciting and so different.
Well, that's fantastic. It's great to hear that cultural concept of the willingness to say yes is pervasive throughout the culture at Ochsner, from the executive leaders in pharmacy, nursing, and the administration to the folks that are doing the work on the front lines. You won the Pharmacy Vision Award in Innovation for your project on pharmacists' expanded role in administering medications. What was the need that prompted this?
From a nursing standpoint, we knew that in the 20th century, we would have great difficulty filling the needs of the nursing world, whether that was at the bedside and beyond. It was a vision. It had been tried in the past along with virtual nursing. How can we help that bedside nursing stretch to take care of patients, and what could we take off their tablet to allow them more time to give that care? And here came the pilot.
At the time that we were starting to develop this interdisciplinary care plan, we were working in a flexible development workforce group, and we were trying to address many critical shortages with many disciplines at the bedside. This was right after the first wave of the pandemic. We were also developing a dependence on external nurse agency support. It was critical for us because not only was it a huge financial burden, really taxing our healthcare resources and affecting many other programs, we also often couldn't get enough support at the bedside, and we were concerned about patient care. At the time, LPNs were more in abundance than RNs, than nurse technicians or nurse assistants, than pharmacy technicians. LPNs were ordered, but there are certain tasks that is beyond the scope of an LPN's practice. We are lucky enough to have 2 colleges of pharmacy very close to us here in the greater New Orleans area geographically. I won't say there was an overabundance of pharmacists, but there were a good supply of pharmacists that we could hire on as direct hires and then use our ability to grow and develop them to meet a need. That was our vision, to transform our model of care based on the available talent pool that we could recruit and retain here locally.
So it sounds like the need was identified due to the fact that you were having shortages of drugs and shortages of staff. You were using a lot of agency staff. So what did you ultimately end up doing, and how did you go about accomplishing it?
For Ochsner Health, our primary goal is patient safety, always putting patients first. We saw that there was an opportunity during COVID where our medication safety goals were not necessarily at risk, but we wanted to reinforce that we were always providing optimal care to our patients. One of the first ways that we were asked to reinforce this structure was actually in an outpatient setting. Let's go back in time to the beginning of COVID, where monoclonal antibody therapies were brand new for us. Our emergency departments and critical care units were overflowing. Staff were getting sick. We were experiencing severe staffing shortages for multiple disciplines. The administration of Ochsner came to us and said, "Are you able to help us out here?" And what we did in an outpatient setting first was put pharmacists in a medication administration position. So we worked in a modular care team with a nurse and paramedics. Paramedics were so critical during this time. They were available resources. We had gotten a federal grant at this point to bring in paramedics to help reinforce our staffing structure. Those paramedics were able to start lines for us while pharmacists were educating and going through restriction criteria with our patients to ensure that they were appropriate candidates for monoclonal antibody therapies. Because this would happen in an ambulatory care setting, our goal was to keep those patients out of the hospital. By bringing pharmacists into those ambulatory care sites, we were also able to keep nurses in inpatient units. We sent more nurses into the emergency department, into critical care units where they really were needed. With this staffing model becoming so successful in the ambulatory care setting, our administration stepped in and said, "This is working really well in our emergency use authorization COVID clinics. can we trial this inpatient? That's where pharmacy's ability and vulnerability to step up to the plate and to try to be that stopgap really came into play. Multiple minds came together and we tried to come up with the best pilot program to insert pharmacists into an inpatient medication use process and expand the role from operational and clinical services that already support.
Thank you, Johlee. I would like to add a little bit more about the Flexible Development Workforce Group that was led by Melissa Adams, our CNO locally here. That group had several administrators and clinical leaders involved with it, and they were looking at the whole model of care for how we administer care to the patients. And they took several different disciplines, not just nursing, not just pharmacy, but spa techs and other administrators and pharmacy technicians and pharmacists. And they looked at all of the disciplines to see who had what skills, what were their scope of practice. And they asked about the scope of practice to see what could we do to transfer some of those transferable competencies to another discipline that was available. Basically looking at what talent do we have and then what could we grow and develop to try to meet the need. So we really looked at the entire interdisciplinary care team and came up with a new model to address the needs. One colleague that I didn't mention earlier, Emily Webb, she was a project manager with Ochsner for several years. She did a very intensive time study where she looked at all of the tasks and times that nurses undergo during a 12-hour shift and looked to see how are they spending their time and what are they doing. When we analyzed that, we looked to see where were the opportunities based on the talent pool that we had. Medication administration was one of the biggest tasks at nearly 30% of the amount of time. That's why our administrators and our clinical leaders said, who else could potentially administer the medications to help relieve the burden for our nurses? Either pharmacy technicians or pharmacists were asked. They asked us, can pharmacy technicians perform this task? And at the time, the scope of practice in the state of Louisiana would not allow pharmacy technicians to administer medications. Very recently, that has been changed, and they can now immunize in the state of Louisiana. But other states do allow and did allow technicians to administer medications. So that would be possible in other practice settings. But here in Louisiana, we had our pharmacists. We had the EUA clinic that Johlee had already trained those pharmacists on how to administer IV medications, higher risk medications. They already had that skill. So then when transferring those already trained pharmacists to an inpatient team, we had to teach them the rest of the skills. Oral medications, topical medications, IV push. They already knew how to do IV infusion. 97% of medication administration types were included in our pilot. This group, involving 2 different campuses at the time, along with Johlee from the system, basically evaluated all of the different opportunities, all of the types of medications, and then came up with a plan whereby everyone would feel comfortable and that they were competent and confident to safely administer medications. Veronica mentioned the nurse preceptor concept. That is the vernacular and language in nursing. When a nurse trains another nurse, they call it nurse precepting. The concept is a little bit different with pharmacy, and we use different terms. But initially, we chose to have nurse preceptors for our pharmacists because we knew that that would help the nurses feel competent and confident in the pharmacist's ability to perform this task. So it was as much cultural as it was technical.
Not as precise as what Lisa said on our end. It didn't look as organized as what it did in the end. And what it looked like for us, just initial, we were the first unit to bring that on. We did get 2 pharmacists that had some skill set from the main campus. We did want to set everyone up for success, and we did start them on a unit that was better staffed than most at the time. There was a large nursing shortage and some burnout going on, especially during the wave of the pandemic, and they started started the pilot and the instruction. There was a lot of voice of the customer. There was a lot of feedback on both ends. And yes, it did prove to take about 5 hours off of the nursing workload, but it wasn't always a well-oiled machine. I don't want to discourage anybody who doesn't have all the nuts and bolts that we may have been privy to when we got this program well started. And Johlee spent many long hours here in conferences that we need to be real about it when you get started on something like this, because it was a huge undertaking, a great vision, but nurses had never trained pharmacists before, and pharmacists come out of school well educated, but they don't come out of school with that skill set at all. There was a lot of back and forth about what is an IV tubing? How do you do a piggyback? What if the patient just doesn't say yes and put the pill into their mouth? So I want to know it's all real, what they experience and how they cross the line, because later when we speak about the success of the program, there's a lot of challenges until you get to the success, but don't ever give up, because you'll see in the end about the benefits that we have achieved from this program. We started with just 2 pharmacists on a very busy step-down unit, and then we got to the point of it started with nurses precepting the pharmacists. As we went along, we got to train the trainers. So pharmacists training pharmacists, and didn't really take too much of the nursing preceptorship when we got through it all.
Thank you, Veronica. After the proof of concept pilot at Ochsner Kenner, where Veronica is, we had established that pharmacists, nurses, and the other members of the interdisciplinary team could work together to administer 97% of medications. They had gotten to a certain point of building that team and what that team looked like. When that pilot transferred to the Ochsner Medical Center West Bank campus, our CNO said, this is a great place to start, but we need to maximize productivity while maintaining safety. At that point, we used the lean process improvement principles with rapid cycle improvement and task and time studies to increase productivity so that we could justify to our administrators the cost of a pharmacist providing this service. I want to address the elephant in the room in that pharmacists are highly compensated employees. It's important to be able to justify that financial expense in addition to all of the clinical and humanistic benefits associated with decreasing nurse burnout and improving retention and improving employee satisfaction and patient satisfaction. Many rapid cycle improvements got us to build that team up so that our pharmacists could support a team of 3 nurses and 14 patients, along with the other disciplines. At that point, we were able to put pen to paper and say, can we expand based upon this level of productivity and safety? And that's when we were able to expand from the telemetry unit to the other side of the telemetry unit and have 7 days a week coverage, 12 hours per day on telemetry. And then we were able to expand to MedSurg to have MedSurg coverage 7 days a week on both units. The interesting thing is that the communication plan was quite different when we expanded to MedSurg from when we initially started on telemetry. Because at that point, the nurses that work on telemetry, some of them also worked on MedSurg, and the word was already out how great it is to have pharmacist support on our care teams. It was a very different conversation when we spread to the second floor.
What you've really demonstrated is a very creative use of your professional staff. And it's incredibly forward thinking and visionary to say, we have a shortage of staff in one area and we are reasonably staffed in another. And how can we flex between these disciplines? Very unique the way that your organization looked at this. And I think it also demonstrates a commitment to your workforce, because you're not just looking at necessarily reducing FTEs in one area because of needs or lack thereof. You're looking at how can you keep your workforce and utilize them in different areas. So I really appreciate that. You had mentioned something about 5 hours off of the nursing workload. What were some of the other outcomes from this work?
Our HCAP scores, so our patient satisfaction with their care, increased substantially to the 90s and now consistently close to 99% for patients feeling very knowledgeable about their medications. Because when we rolled out the program, the pharmacists don't just administer medications. They also educate every patient every time using the evidence-based best practice teach-back method. Because of that, our patients ended up feeling very knowledgeable about their new medications, the side effects of those medications, and what to do if it occurs. We also train them to write that information on the whiteboard so that it's available, and that has been very successful. And patient satisfaction is very important for our patients and our team members. The nurses were able to expand their staffing ratios safely from 1 to 5 to 1 to 6 when they had coverage. And that helped us to decrease that external nurse agency support. And we were able to document savings of $3 million per year by eliminating external agency support. So that was tremendous because that was really taking a toll on our organization as a whole. We were able to increase safety by decreasing medication errors. At our campus, we would average 10 to 15 errors per month. Some months now we have 0 medication errors. I knock on wood because I'm superstitious. Sometimes there's 1 or 2 or 3 now, usually related to controlled substances that we would document. So an increase in safety due to that collaboration communication. We were able to document tripling the nurse communications with the team, the interdisciplinary team, by doing another time task study to compare to the initial one, and a 68% relative decrease in the time that nurses spent on medication administration. The nurses still do administer some medications. We don't have coverage during the middle of the night, and unfractionated heparin is still a medication that the nurses administer because that's a policy that applies to all 46 of our hospitals. So we don't want to deviate from that just for the pilot. There are a couple of select medications that weren't included, but for the most part, a huge burden was taken away from the nurses to allow the nurses to operate more top of license, doing what they love to do, which is assessing patients, talking to patients at the bedside, and communicating with the team.
In addition to the education that Lisa did speak about, the pharmacists do all first dose medications education, as well as it provides an extra round on that patient when the pharmacist is going into the room as well. So another set of eyes on the patient. We have statistics that show that our readmission rate for non-compliance has also decreased. So many great things are happening.
Thank you, Veronica. That's right. And our pharmacists administer between 100 and 120 medications per day. So over 14 patients. It is a really substantial amount of work that is happening there to support our interdisciplinary team.
I agree, Lisa. And to round out this vision for anybody listening and wondering, I wonder what else these pharmacists might get used to do. These pharmacists are also helping with transitions of care. So you could say we are the drug experts. We are now infused into this bedside medication administration process, taking over more than 97% of medication administration, greatly helping to round out educational efforts, increase HCAP scores. At certain campuses, they are also helping to take over admission and discharge medication reconciliations, greatly helping to increase with discharge education efforts. And we also put these pharmacists through ACLS training, so they are another resource at the bedside during code situations. I hope that helps to just paint a picture of what you might use these pharmacists for if you try a pilot at your institution.
Also, med reconciliation. When patients bring medications that some are even confused about, and those pharmacists go through their medications and make sure that all the meds that they were at home are reconciled prior to their admission and then again upon discharge.
So what surprised you about the process?
What surprised me, not initially, but like anything else, you don't know how each individual pharmacist versus nurses are going to react and what is going to be the long-term outcome. But now seeing this program a couple of years in the making, it just gels, for lack of a better word. The pharmacists who in the beginning, like any other discipline, you have your favorite area to work, or maybe you don't feel like going to this floor. Now they feel part of the culture and they're ingrained. We're talking about all the great things that they're doing in medicine and with nursing, but we have other surveys that go through our campuses on stroke and patient experience, but they know about it and they want to know about it and they want to be part of the team, and they are part of the team. It is great for culture having a multidisciplinary approach to patient care, and patients want it too.
I love that you mentioned culture. As a med safety nerd, I think culture is top of mind for me all the time. Coming into the Kenner campus, when we first started this pilot after the EUA, there was a very natural protection of job duties. Nurses would say, this is my patient. Rightfully so. You own that patient when you walk into that shift. And we have some of the best nurses at Ochsner. And pharmacists were brought into this method to be a supporting resource, to add drug expertise to this process. But there was a unique conversation. There was unique preparations that we had to have with the teams to transition from protection of job duties to willingness to accept support and help. One of my favorite surprises in wrapping up the Kenner pilot was hearing a nurse say as part of an exit survey that I would much rather keep an expanded nurse ratio than go back to a smaller patient load without a pharmacist help. What an awesome quote. That just speaks to the level of teamwork that our pharmacists brought in, the open arms that our nurses welcomed us with, that did not come without hours of communication and hours of shadow shifts. This was a team effort, and to hear that nurses wanted their pharmacists there, now they are requesting these resources to be expanding to additional units. That was just the cherry on top.
Absolutely. And that is what happened at the West Bank campus once we expanded in telemetry, that the MedSurg team asked the CNO during listening sessions, when will we get pharmacists? And that is how we expanded from telemetry to MedSurg. The process change communication was very, very different with that expansion versus the initial conversations that we had bottom to top to, instead of convincing them what was in it for them, they already knew what was in it for them. And so that was a very pleasant surprise how our culture has evolved to embrace our pharmacists on the interdisciplinary care team.
It's fantastic to hear about that expansion and really the cultural progression that you experienced from the initiation of the project to where you are now. If other folks are considering implementing something like this at their organization, what advice would you have for them? And also, what are your future plans for the project?
One of the most important things at the start is to have those conversations with the subject matter experts, with the team members, and find out what it is they feel like they need. And then gear the development of the program to what they need and what they want, and communicate early on what is in it for them, basically using change management skills from the bottom up, assessing the talent that's available, having those stakeholder conversations early on, and communication, because that has been the key to our success and our continued success. It's a lovely, wonderful program, but it's not perfect. There are personalities and issues that come up, but we address them openly, transparently. We have monthly meetings with the administrators and leaders and the stakeholders. During those listening sessions, we find out what's working and what isn't, and then address and adopt as needed. And that has been the secret sauce to our success.
Reassess your program as well. We had to reassess shifts. We thought that we could cover 16 hours a day. When we reassessed, 12 hours was adequate. Even though your program seems to be in the right direction, reassessment is always necessary.
Veronica, I think that was beautifully said, and it leads into what we're looking to expand to in the future as well. So we have this program up and running at 2 facilities currently. Those are excited to expand coverage into additional shifts, whether that be further into the evening or even considering night coverage, as well as expansion into different departments or units. We mentioned transitions of care was a huge opportunity for this program, and expansion of these services recently into the emergency department has been very exciting for these 2 campuses. We're also getting requests from other facilities and other institutions within Ochsner and outside of Ochsner. So we're honored. We're really excited to be a resource to expand this program locally within the Louisiana region, as well as helping other facilities work through some of these initial stumbling blocks that we went through. We hope nobody has to recreate the wheel, keeping in mind that our practice model works for our patient population, and we're really excited for you to find a practice model that suits your staff and your patients.
Well, great advice from all 3 of you, and I wish you all the best in the future with this novel model. Thank you all for your expertise and insights. It's been an absolute pleasure having you on. And listeners, please join us for more Verified RX podcasts. Subscribe today, like us, and send us your comments. We'd love to hear from you. Verified RX is your prescription for success and is brought to you by the Vizient Center for Pharmacy Practice Excellence. I'm Gretchen Brummel. Thanks for listening.